Yes, hello. Great to see you yet another day. It's always pleasure joining you in this conversation. Our conversation today will focus on health matters, to be specific on matters of reproductive health among women. We are going to talk about endometriosis. What is this endometriosis? And some bit of hybrids. We get to understand the differences between the two. I'm your host, Nixon Njau, and you know what? There's a perception that this conversation shouldn't be talked by men, but today we are two men army. Follow us throughout this conversation. I'm having my guest today is none other than Dr. Joe Njagi. Welcome to the Kenya Times.
Thank you very much, Nixon, for having me.
Let's begin. There's someone who is watching you and hearing you for the first time. Who is Dr. Joe Njagi?
Well, that's a Dr. Joe Njagi. I would say is a young village boy from the highlands of Mount Kenya, specifically from a place called Kirinyaga, who has had an opportunity to travel the world and to have great experience in healthcare, and who has great passion in women reproductive health, specifically endometriosis. Mm-hmm. So it's really great to have this space to talk about a condition that is very dear to my heart. And thanks to you and to the Kenya Time for creating a space where we can talk about now this condition that has been recognized as one of the underrated condition.
Mm-hmm. Thank you. It's always a pleasure to have you here.
Thank you.
Now let's begin. What really made you to specialize on endometriosis, not any other, disease?
God, I think that will possibly take an entire show to walk you through the journey. But to cut the story short, I like to put it this way. I believe there's God, and He had purpose for each and every one of us when He was creating us. And I want to believe that His purpose for me was to be an endometriotic surgeon. Now, just to kind of give you a little bit of what it takes to get to the level that possibly endometriosis specialists are. So you first finish your postgraduate in obstetrics and gynecology. You have to be conversant with the minimal invasive surgery, what we call laparoscopy, and then you start the journey into perfecting the skill, and now into endometriosis to a level whereby you become advanced in management of endometriosis. It's a long curve, and just to mention, there are not very many. Not only in Kenya or Africa, but globally. And I think that's why endometriosis has not been given the attention that really requires. So for you to become an endometriosis specialist, you have to be quite advanced in terms of skills.
Mm-hmm.
Yeah.
And what really made you to do what you're doing actually?
I would say I never chose endometriosis. Neither did I choose to become a gynecologist. It's just a story where a door opens up and you find passion. So I finished my postgraduates 2016, and I started operating, and I got introduced to laparoscopy, which is minimal invasive surgery. This was in Aga Khan, not accessible in the rural area. And it blew my mind. So there was only one problem. Why is it that women in the rural cannot access this perfect technology? And because of cost. So we worked around and tried to demystify that laparoscopy can be accessed. And we came up with laparoscopy machinani, which was, something that I started. Now, with doing more laparoscopy, we started seeing something that was very peculiar. That was endometriosis, which in most cases you'd miss it when you're doing open surgery. And we came to learn that endometriosis is a big problem than we can ever imagine. And of course, somebody had to sort the patient. So we started training and we traveled abroad and started having interactions with world-renowned endometriosis specialists. And there we were. We found ourselves in this space. And over the years, I would say that we've become good.
It's been an amazing journey.
It's been a journey, amazing journey. And there's nothing that gives me fulfillment than when you help a patient who has suffered endometriosis, misdiagnosis, multiple surgery, infertility, lost work, lost marriage, cannot have sexual intercourse. Can you imagine? Just one condition. They come back for review and they tell you, God bless you, I have my life back. That's it.
That's it. Something that I was not able to do, now I'm able to do.
Can you imagine? You have to plan your life around your menses. So for you, if let's say I say, hey, what's up, Nixon? Can we go to Mombasa, just chill out for this gig?
For vacation.
For vacation. You want to look at your calendar and you see, okay, who do I have to interview? Okay, fine. I can reschedule, there's no problem. Hey, what's up, Dr. Njagi? I'm cool, we can go. You can't do that with endometriosis. So, hey, can we go for whatever gig or let's go on vacation? You have to look, oops, I'm sorry. Those 5 days, I'll be on my menses. I cannot defer. I have to, lazima niti. Sorry, I can't.
And Dr. Njagi, let's talk about the state of awareness on matters of endometriosis. We have seen various, influential figures giving out and even testifying their journey with endometriosis. And even some have succumbed due to endometriosis. What is the state of awareness in Kenya right now?
Things are better, Nixon, than, 2 years ago. And I think, let me say, the challenge starts with the healthcare system. Why am I saying healthcare system? If when I trained, there was no emphasis on endometriosis. And we'll talk about why there were these challenges. But now we are finding solutions. So then that means that we talk about a condition we don't know about. What is creating awareness? It's creating awareness is saying there's this problem and these are the solutions. But you cannot say there's this problem, which does not have a name. So I'm having period pain. There's a lot of myths surrounding the period pain. So it was not clear. So that was a problem. Are we just going to talk about, we are having painful periods? What does that mean? Does it have a name? Does it have a diagnosis? What is the option of treatment? So that was a challenge with awareness. Have women suffered from these symptoms? Absolutely, yes. But now when we started saying, hey, wait a minute, you're having painful period, you cannot go to work, there's issues with infertility, sounds like endometriosis. What do we need to do? We need to do ultrasound scan, which is going to be done by an endometriosis expert. And then we do ultrasound scan, boom, it's there. Let's say we don't find it. We still say your symptoms are suggestive of a condition that has a name, endometriosis. Now, what are the options? These are the options of treatment. Now we are creating awareness. And the creating awareness is stating now, hey people, painful period is not normal.
Why?
Because it's not normal.
And many ladies actually experience the pain during, that time. Why do you say it's not normal?
Because I think this is the misconception. It's felt to... Okay.
Bring it on.
Let me bring it on. So let's first understand what has been masked is what we call cramps. All right? So,
oh yes, cramps.
Cramps, not pain. It's different.
You want to tell me cramps is not pain?
Oh yeah, of course. Of course. So what is cramping? Now, let's take a little bit of anatomy. Let's go back to the uterus. So a uterus, we know it's an organ made of smooth muscles. And these smooth muscles, we know muscles contract. So why are these muscles contracting when a woman is on her menses, is because she's shedding off the inner lining, which we call the endometrium. So when it's shedding off, the uterus needs to contract to expel the content. So it's just going to be a little bit contraction. The same thing when a woman is delivering a baby, the uterus will need to contract to expel the baby. So ideally, that is the cramping. All right? And when a woman is delivering, we never call them cramps now. We call them contractions.
Contraction.
Okay? Yeah. Which, contraction is this, unpleasant sensation.
Yes.
Now, when you have pain, and in most cases, normally, a woman will have, okay, fine, during my menses, it's okay, I'm having cramps, bleeding 3 days, cool, no problem. I can go to work, I can go to school, I can do my stuff. I really don't have to take painkillers, I don't have to go get shots for pain. Now, what is pain? Pain is described as a sensation that indicates this tissue damage. All right? So if I pinch you, you're going to feel pain because I'm traumatizing the tissue. All right? If you get pain, well, or let's say this sensation, let's now be straight up, not cramping, pain, whatever, and you have to take painkillers. You will actually feel, no, I'm not okay today. I'm not going to work. So maybe here, your colleague will, your team here will say, you know what, Nixon, today, I'm not feeling too good. They might not be open. It's that time of my month, and I feel that I just need to sit home. I need a hot water bottle. Things are not getting better. That's not normal. Unfortunately, we have normalized the pain. Oh, no, it's okay. You need to be a woman. You need to toughen. Women need to be tough. You need to endure the pain. If you cannot endure the pain for menses, how will you endure the pain of bearing a child? You're getting me? So then we try to make it this is normal. And then women get on this now myth that ideally I should be going through this. And this is part of being a woman. Come on, man. No. It's actually, by all means, it's actually not right. Now the problem, you come to healthcare system, and I'm not okay. You find an early Dr. Njagi, who has just graduated from medical school, and he's going to say, oh no, this is very normal. Don't worry about it. It's something called hysteria.
Hysteria.
Hysteria. Don't worry. As you get older, it's going to get better. No problem.
It's gonna be well.
It's going to be well if you get pregnant. Can you believe? I had a young lady, 17-year-old. She got the pain, and she was told the only way, her mother was told the only way to get her getting better, she get pregnant. She get pregnant at 18.
18 years.
Delivers. 6 months after delivery, the same pain came back. This time, worse. Now, this is the reason why we have to emphasize that this pain is not normal. For me, I don't care what anybody else says. I don't care who you go to, whatever physician, they say it's not normal. And we have to look for what the problem is. We don't treat, you go, you have MRI, and they say, oh, MRI is showing it's no. We're not treating the MRI. We are treating the patient and their symptom. So we need to validate.
Actually, we are learning today, and we are two men army. There's a perception that men shouldn't talk about women's conditions like this. But we are breaking barriers, and we have to talk about it. You are saying period pain is not normal at all.
Absolutely.
And it is a perception that is in the minds of many women.
Absolutely.
That you know what, if you have pain, it's just normal. After the periods, it will end. Now, these patients come to you, and she tells you, Dr. Njagi, I've been suffering from this pain, blah, blah, blah. What do you do first from there?
Basically, the journey for a patient. Let me say that almost always, the moment the patient. Now, let me just back up a little bit. There's a bias because I'm an endometriosis specialist, and that's what I really get to see. So I know by the time patients, I would say 90% of the patients who come to my clinic are going to be patients who either have fibroids, gynecological conditions. I don't do obstetrics. The first thing is, as a good physician, you have to have an open mind. You gotta get outside the box and listen to the patient. So you have to listen, all right?
Keenly.
You have to listen. And it's not close-ended question. When did this pain start? No, I'm asking, is it 2 years, 3 years? Let the patient tell their story. What I've come to learn is that for patients who have had this chronic pain, they have normalized that and they think that is not important. And they will only say that as a sideline. That's very important. So you need to listen to the patient. Let them speak their heart out. Give them time. 10 minutes, 20 minutes, let them speak
To
up.
express
To
themselves.
express. Even when you think you know it's that one, always ask yourself, what if it's not that? What else could it be? So the story will be, I've been having this pain, just what we have talked about. The pain possibly started when I started my menses. So as early as 13 years old. And pain started, I was being given medication, I was in school, the nurse thought, that's usually the story. When you start like that, smell, think, feel, sense endometriosis. The pain got worse. The pain was during my menses. My menses, were terribly painful. That, I could not even sit my exam. Of course, the story goes, I started using ibuprofen, I started using diclofenac, hot water. It was helpful. I was given pills by my doctor. Menses were away. I felt slightly better. Can be nothing else. I mean, it can be nothing else. Story goes, I went for an ultrasound. This is where now things start getting bad. So up to this point, symptoms suggestive of endometriosis. I went and I had an ultrasound scan done, and I was told everything was normal. So I started to believe it's in my head. The pain got worse. I had surgery. Do you want me to traumatize your heart a little bit?
It's okay.
Okay.
Go on.
Okay.
You're in a learning
And
session.
when I went to have the surgery, they removed my ovary. I'm not making this up. This is the stories that we get to hear from this patient. And after 6 months into recovery, the pain came back. I started getting strong painkillers. And now, patients started depending on painkillers. Now, at this time, you're talking about 7 years into this whole process. And then you say, okay, wait a minute. So that's what we call the history. Listen to the patient. Now, up to this point, you have had conversation, you say, your symptoms suggestive of endometriosis. I cannot think of anything else. It has and it can only be endometriosis. And I only say it's not endometriosis up to a point where we rule it out. I'll tell you, more than 80% of these patients, it will be endometriosis, nothing else. So then after that, we say, okay, fine, let's do ultrasound scan. So ultrasound scan is an imaging modality that helps us to, evaluate. Now, again, remember, I said it has to be done by a skilled personnel who knows how to look for endometriosis. So we do ultrasound scan. Sometimes we are going to pick it up. And we are going to see certain changes and say, look here, this can only be explained by endometriosis. This can only be explained by endometriosis. Sometimes the disease is too much. It's too much that you find that it's affecting the ovary. So you have a cyst on the ovary, something we call endometrioma, or a chocolate cyst. You find sometimes it's behind the uterus, and it's infiltrating the intestine, and there you go. Bingo. And you tell the patient, you know what? You have endometriosis. And what they do, they look you into the eyes and they cry. And they ask you, you want to tell me all this time I've had endometriosis? And you say, unfortunately, you've had endometriosis. So usually when the patient comes to us, that's the journey. That's how it's going.
That's the process.
That's the process.
Now, pain is one of the symptoms
Yes.
of endometriosis. Yes. Let's come back to the factory setting before we now dive into the conversation about endo.
Yeah.
We go deep.
Yeah.
What is endometriosis? And maybe how does it affect those who have it?
Yeah. So endometriosis, now, going back to the definitions, endometriosis. Endometriosis, we say, let me give a little bit of anatomy so that it can be clear to our viewers. So the uterus has 3 layers. There's the inner one, there's the middle one, and there's the outer one. We've already talked about them. So there's the inner one, which is called the endometrium. Endometrium usually sheds off, thicken. So that's why a woman is getting her menses. So menses, it means she's not literally bleeding. Some would think the menses is the egg that is, is coming out. The menses is just the lining that has shed off. Why does it thicken? It thickens for one reason. If this woman get fertilized, now the fertilized egg is going to be moved into the uterine cavity. It's going to find fertile ground, thickened lining. It's going to be implantation. And that becomes the life of me and you and everybody else here. Beautiful. Now, the middle layer is the muscle layer, the one that we say usually give cramping, contractions, depending on what period. Now, we say endometriosis is a condition where you have tissues similar to the lining of the uterus, or this one we are calling endometrium.
So it is a condition, not a disease.
Well, okay, it's a disease. Yeah, disease is a condition. Yeah, it's a disease. Now, the reason why okay, well, that's for another day. So call it a disease, call it a condition. So it's a disease where tissues similar, and there's a reason why we say they're similar, to the lining of the uterus start to grow outside the uterus. And I know the next question you get, how do they get there in the first place? Okay.
I was coming there.
You're coming to that. So we call that endometriosis. Now, there is another cousin of endometriosis called adenomyosis, now that we are talking about definitions. If you have similar tissue now infiltrating this middle layer, the muscle layer, now that's called adenomyosis. And last but not least, we have the endometrioma. Endometrioma are these cysts of tissue which are similar to the lining on the ovary. So those are the 3 classical definitions of endometriosis. So in the event, now we have the tissue, or we have, similar to the lining outside, that's endometriosis. Just jumping how, and I think this is still again what makes endometriosis quite difficult. It's still not clear how endometriosis develops. There are many theories.
The causes are not much understood.
They are not understood. So it's called a disease of theories. So there are theories whereby some think is what we call retrograde menstruation. So when this woman is menstruating, this content can flow through the fallopian tube, spill in outside the uterus, and then they are going to attach on the side wall of the abdomen and start growing. There are others that have stated that during the development, do you know you started, you're a very complex being, but you started from...
Bring it on, Dr. Njagi.
You actually started from a very small, tiny cell called a sperm and an ovum.
Something small.
Actually, very small. It was actually started as a single cell, and then it started differentiating.
Then I'm tall like this.
Then you're tall like, all right, and as handsome as you are, and that was coded by something we call the DNA. So during this process, some theorists state during this process and differentiation, what is going to become the eye, what is going to become the ear, what is going to become the testes, what is going to become the hair, all this was determined by your genetic code. So during this, development, some theorists state that when the lining or this lining was developed, this tissue could have been left somewhere else. And that possibly is true because you've heard of endometriosis being found in the diaphragm.
Sure.
You've had endometriosis
Even on the chest.
in the chest.
True.
You've had all this. We've seen endometriosis in the eye. We've seen endometriosis on the, tip of the nail. We've just seen endometriosis just about anywhere. So the question, how did it get there in the first place? A little bit complex. So the most important thing as we are now, as we're having conversation, or what we know now globally, we need to make the diagnosis. We need to make the diagnosis early. We need to create awareness. We need to start busting these myths. And I think that's why I'm really glad that we're having this conversation, that we can,
and bring it into a bigger conversation.
Exactly. Yeah.
And so you mean endometriosis is a growth?
Yes.
It's something like a growth.
Call it that. Call it that. And hopefully you'll fix an image from whatever for this
Sure.
conversation. So when you have this tissue growing, let's say assume this is the lining inside the abdomen, and this is the lining, and this is how it should be. So when you have this tissue now, a growth you call it, is going to attach, let's say, a small tiny one. Sometimes it's very tiny, microscopic, you cannot see it. And then what will happen, it will start growing and growing and growing. All right? One of the reasons is because the reason why we are saying this is similar to the lining of the uterus, the same way the lining is responding to hormonal changes, the same way this tissue is changing. So this keeps growing. And it's usually dependent on the woman hormone called estrogen. Now, unlike the one that sheds off and it's picked up from the pad or tampon, this one it just have nowhere to actually be expelled. So this keeps over time. It keeps growing and growing and growing and growing. And that's why I was saying you can have severe disease to a point whereby you have as big growth, call it, we call it nodule, as big as this. You can find it infiltrating on the intestine and going through and through, and sometimes you find it on the diaphragm. So it has a tendency of growing. However, when you say growth, I was very careful. Because when you start talking about growth, people might think about cancer. This is not cancer, and it doesn't have high risk of turning to cancer. So that's a good thing. However, it behaves like cancer. It's not cancer, but it behaves like cancer because we know it's going to infiltrate or invade organs and other tissues, and that's what really brings about this complication that come as a result of the disease advancing.
And earlier on, you mentioned about pain being one of the symptoms to spot endometriosis.
Yes.
What are some of the other symptoms that as the professionals you can see when the patients when the patient talks to you, you can know that this one is endometriosis.
Tell you what, patients who have cyclic pain or pain during their menses, a condition called dysmenorrhea. And I'm stating this for our viewers because there are some who go and they are told, your diagnosis is dysmenorrhea. No. That's a jargon in medical that's saying that you have painful period. Okay. So the first one, about 80% of patients who are going to come with cyclic pain every time in their menses, which we've been talking about, they're likely to have endometriosis. Other symptoms are going to include things like infertility. So if the disease is advanced, they are trying to get pregnant, they are not getting pregnant, that can be an indication of endometriosis. As a matter of fact, statistics state the following. Up to 50, it's a big number, up to 50%
of the
women who suffer from infertility, they could be having endometriosis.
Really?
Let me break,
it might be, there's high possibility that
It's endometriosis.
it is endometriosis. Why don't we have our own statistics as Africa or even Kenya?
I think because we are not many. So if you ask me what is the real challenge, it's because we have challenge with our data record, all right, and getting the accurate diagnosis. So it becomes very difficult.
Because during my research, when I was preparing for this bigger conversation, I was trying to look at the statistics in Africa and even in Kenya maybe,
Yeah.
but there's none. I only found the one from WHO, the
Yes.
Western statistics,
10%.
saying that at least 1%,
10%.
out of 10%,
Yeah. Out of 10, one has
out of 10, one has the endometriosis.
I think we have our own local
Statistics.
challenges.
Challenges. Okay.
Challenges.
Okay.
And you find that these conditions that have not been given the
Much
attention that they deserve, who cares about it?
Okay.
Who cares about looking at statistics for endometriosis? And basically, statistic will include the following. Out of 100 women who has come to, let's say, Kenyatta National Hospital, how many of these patients have endometriosis? That's how we get statistics. But we've already discussed some of the challenges in getting and coming up with a diagnosis for endometriosis. So you still have patients who have the condition, but they have not been picked up. So if we get this data, in most cases, it might be misleading. All right?
Not
if you
correct.
ask me, I now feel that the statistics for endometriosis among African women, it's more than the Western data. We possibly maybe about 20%.
So for now, we depend with the Western
We have to
statistics.
depend on the Western statistics.
Let's come back now to our conversation. We were going to the statistics.
Yeah.
Now, you have talked about infertility. And do women with endometriosis give birth
Yeah.
or get pregnant?
Oh, absolutely. So it does not mean if a woman has endometriosis, she's not going to get pregnant or she's not going to deliver. Now, endometriosis has different severity. So the mild disease is the moderate disease, the severe disease. And mild disease is, early when the disease is starting. So these patients might not suffer symptoms from endometriosis. As a matter of fact, the women who have pain, conceive, deliver 2, 3 babies, only to come and learn that they still had endometriosis. But the endometriosis was not significant or was not advanced enough to cause infertility. So we need to understand how endometriosis causes infertility. I talked about endometrioma. I also need to talk about this, tissue sticking together from the inflammation. So that means the fallopian tube gets stuck or the fallopian tube get blocked from endometriosis. So in this patient who have advanced disease, it's going to be difficult for them to conceive. And of course, that will mean they have infertility. However, if they get pregnant in whichever way. Most patients are going to carry the pregnancy. We don't find the pregnancy being complicated by endometriosis. But remember I talked about the cousin called adenomyosis. Adenomyosis has a tendency of complicating
The pregnancy. Okay.
Yeah.
So meaning they can have intercourse
Oh yeah, absolutely.
with no challenge, with no pain.
There is. With advanced disease. Now, we had not finished the symptoms. Now, coming back to it.
Yeah.
So, and I'm just going to just mention them, So, one we say pain during menses, pelvic pain, infertility. They could have intestinal symptoms, bloating, pain while passing stool, if there's disease that is infiltrating the bowel. Pain during sexual intercourse. As a matter of fact, we find most patients will have pain during sexual intercourse because we have disease that is below the uterus, just about the level of the birth canal or the vagina. So with deep and the pain during sexual intercourse is very specific. is going to be pain on deep penetration. Other patients are going to present with fatigue. I'm always feeling tired. What about mental health? Mental health is big. Women are going to present with depression because they have had this pain. No one seems to understand them, and some will, will even become suicidal. We've seen patients who now on antidepressants. So all these symptoms can be misinterpreted, but they all could suggest you're dealing with endometriosis. So again, just now going back to the question you're asking, is sexual intercourse a problem? It might not be a problem, but if the disease is advanced to certain stages, then you'll also find that women having pain during sexual intercourse, then they're not going to have sexual intercourse, because it becomes, and what's going to happen if you're, and I'm really glad that we are saying now, we're talking to the boy child. Men are also responsible. Actually, they should be part of this conversation because they need to provide support structure to these women. If you have, and I'm always,
there should be a support system.
Yes, I'm always blown away by those men who bring their women to the clinic. By that alone, you've already sorted this woman's problem to about 50%.
Because of the mental.
Exactly. We need to be there. So if she's telling you no, sex is painful, mwelewe tu. But you're too tight. You get it. But as you're giving her and you're giving her time, look for problem, look for solution.
Sure.
Come and see us, and we're possibly going to sort it out and for all. How feeling is good. When the husband comes back and say, "Hey, thank you so much, Dr. Njagi. Now nimerudi game sasa."
So now, Dr. Njagi, we are still continuing with the conversation. And now we were in the symptoms. So those are major symptoms of the endometriosis. Pain during menses. And also the one you've talked about.
During sex, yes.
So once you find a patient is diagnosed with the endometriosis, how do you sort the problem as the professional?
Treatment for endometriosis. I just mentioned them, and then I'll just explain. So first, treatment will include medical treatment. In medical treatment, there are different options. There are painkillers, there are hormonal treatment, so on. And there's surgery. So those are the main options of treatment. So when we talk about medical treatment aims to try and suppress the endometriosis. Surgery should be meant to remove
the growth.
The
endo.
So excising it. Adenomyosis kwanza hiyo
itulie kwanza. Yes, go on.
So, but however, we still know that the surgical treatment is a gold standard. Now, the painkillers, let's say, for example, painkillers. The commonly used painkillers are going to be ibuprofen, is going to be the diclofenac, because these are the ones that are considered non-inflammatory, non-steroidal anti-inflammatory drugs. So they are trying to contain the inflammation, because remember, the pain, as I mentioned, is coming from the tissue injury, something we call inflammation. So you're trying to contain this, which will reduce on the pain. Now, you don't need to be a gynecologist. You don't need to be Dr. Joe Njagi for you to know that if you're knocking off the pain, but you're not taking care of the root cause of the pain, tomorrow the pain will be there. All right? So this is a temporary measure to try and contain the pain. But you ain't doing nothing to the problem. Now, we go to the hormonal treatment. This is where, the combined oral contraceptives we give, and other progesterone, and there are different options. Now, these hormonal treatment, they are meant for two things: to try and stop or hold the menses. All right? Because remember, we say that every month the tissue is also being activated. activate. So we are trying to reduce the cycles of activation with the aim that this is going to contain the disease, the symptoms are going to be less, and we are going to reduce on the growth. However, this is the trick. Endometriosis is very, very, very notorious. It can self-propagate itself. What does that mean? It can say, I don't need fuel from outside. Remember we talked about estrogen?
Yes.
Which is the fuel that makes it. Sometimes it does not even need external, estrogen that is coming from the ovary. It can be able to produce its own estrogen. So it can be able to propagate itself. Now, before I lose my thought, and that's the reason why we say some patients are told, wait until post-menopause or the symptoms are not going to go away.
True.
That's not true.
It will be done.
That's not true, because it still has its way ability to actually sort itself. So the medical treatment, that's what it's meant for. Some it might work, especially for early disease. Some it might not work. And we actually say it might reduce on the symptoms. And now there are all types of this hormonal medication in the market. You go, oh, please take this, take it for 3 months. You go for 3 months, pain is still there. International recommendation, and there's one guideline called ASHRAE guidelines, states the following. If you have a patient who is not responding to medical treatment, all medical treatment is inappropriate. They don't want to take this hormonal treatment for whatever reason. They have other medical condition, or they have believed that this could affect whatever reason, and there's no improvement. We recommend for laparoscopic surgery. Now, this is where I want to.
Laparoscopy.
Laparoscopy.
Hey,
it's a tongue twister.
The terms.
Go on. Inaitwa surgery ya matundu madogo.
Matundu madogo.
So laparoscopy, basically we are introducing a camera inside your
womb.
No, abdomen.
Okay.
So let's call it stomach. But then you take them on a journey. We need to give ourselves time. 6 months, if there's no improvement, we need to think about something else. We cannot keep changing you from
think
this
outside the
medication.
box.
Exactly. We cannot change you from this medication, change you for this medication.
And there's nothing.
Send you for prayer session, where prayers is important. Some will say, mimi hizi madawa zenyu za hospitali nimeenda kwa mganga wa Tanzania, nimepatiwa mitishamba, ikasaidia kidogo. Now, I want to ask patients, unapoenda kwa mganga wa
Tanzania.
Mganga kutoka Tanzania, do you have an idea what content is in this now that you're getting? And that's a big problem. And I think that's something that we should really consider. Sometimes it helps, but I really, and I've seen everything around on social media. Naona wengine kuna vitu wanaekelewa. Please help me understand. I mean, okay, now you have a growth. Umemeza tembe. What is going to completely get this? I mean, how? I still not.
You don't understand.
I still don't understand. Some will say, it's going to make it shrink. What is the mechanism of it making it shrink? Of course, I mean, I've mentioned that we can suppress it and symptoms get better. However, Nixon, not every patient who has endometriosis will have the cardinal symptoms of endometriosis. Therefore, we cannot use pain as a matrix to help us make a diagnosis or be able to tell the severity of the disease. And that's what really makes this disease very complex. I have a young lady who comes to me, her main issue is fertility. And that's why we are talking about all these different, types of symptoms. And she says, her main issue, no, Mimi, I just want to get pregnant. I'm just not getting pregnant. What do I do? Okay, fine. Pain? No, life is good. I just want babies because...
And according to you, Dr. Njagi, your overall view concerning endometriosis, how is it? Is the state of endometriosis? How would you explain it, the feeling and the condition itself?
It's bad.
It's evil.
For one reason, I think it's evil. I mean, endometriosis. I mean, it's a bad evil. And when we lost one of prominent
personality.
Media personality. It was terrible, terrible. And patients who have had diagnosis of endometriosis went into a shock mode. And this means that they also felt that this is a death sentence for me. She's died. And every time you tell a patient it's endometriosis,
She's shocked.
shocked. I would say that was a different, this was advanced disease. Again, as we are talking, and we know very well, she gave her story that she had delayed diagnosis, she had multiple procedures, still no diagnosis. I mean, she had to travel abroad to have this treatment. Fortunately, and I think this is a good thing, Nixon, I mean, we are sitting here talking about it.
Indeed.
We have expertise, treatment options. I will tell you for sure, I will tell you this for a fact. We were among the first, no, we were the first, let me say,
First.
in Africa to, start doing these advanced treatment for endometriosis, including the diaphragm. We were opening the diaphragm. Now, we work with different specialists. We have cardiothoracic surgeons, we have, bowel surgeons. So, these advanced, options of treatment where now patients were going abroad, they're locally available. So as much as we are saying war is a bad evil, let's also celebrate on the improvement and the step that we are making. And now people are making noise about it. So we need to talk about it, we need to demystify it, but at the same time, we need to give people hope. This is not the end
of
life. We catch it early, your life goes back to normal, no issue.
You have treated many women suffering from the endometriosis.
Yes.
Are there some who have come to you and tell you, Dr. Njagi, I was suffering, but thank you, this thing is no more. I'm living my life, I'm now okay, my life is smooth. Have you experienced such?
Actually, go to my social media handle. Because some I don't even know. Some don't even come back. And I think this is the power of social media. It has actually given me feedback, from some of my patients. I'll just find a random message. Yeah, of course, when you operate a patient, 2 weeks, come back for review. But then there's a patient who will randomly write a message on your social media handle and say, Dr. Njagi, thank you so much. Following your surgery, I have a 3-year-old child.
Wow.
Come on, man.
Amazing. How is the feeling, actually?
I hope that the feeling we'll get when we go to heaven. It's going to be, of fulfillment.
Sure.
It's so fulfilling. I don't think there's any amount of money that
can
compensate that. Did you see on my social media? Because you mentioned you follow me on my social media.
I do follow.
Did you see one that somebody brought a goat?
Oh yes. I saw the.
And I'm
video.
like, I did what I needed to do. Everything was okay. Actually, I had treated the wife and the daughter. And they said, Pelekea would, I don't know.
And it were men who brought you there.
Men brought the goat. So again, these are good things. So the fulfillment that you get. When somebody says, you know what, I couldn't pay you, God bless you. Sometimes we even fully waive the charges. I mean, you find the patient cannot even afford. And you're holding the key to end their suffering. You say, no problem.
How does it cost to treat endometriosis?
It depends. Surgery for endometriosis are expensive. Let's start there. Because of course, the skill of the profession, the equipment that we use in theater. Again, remember, I've mentioned you have to use laparoscopic equipment. And laparoscopic equipment are expensive because they're not locally manufactured here. Of course, initially, the medical, equipment, we were not getting VAT now, these medical equipments, so the prices are significantly increasing. One instrument that I can use to cut might cost about 70,000. So imagine meter in answer 70K. Hujaweka pesa ya theater, hujaweka pesa ya daktari, hujaweka pesa ya madawa, hujaweka pesa ya kitanda, hujaweka I mean, hapo ndo mita inaanzia. Now, and that's just like the basic.
What happens maybe for the women from the village who don't even
Have you heard of laparoscopy mashinani?
Oh yeah.
You're
the founder,
I'm
right?
the founder of laparoscopy mashinani.
Yes.
So laparoscopy mashinani, we get a few of us. Once we get a few of us, then we go out and give these services
for free
or for subsidized amount. You know, and possibly that's why I'm still locked in mashinani. Otherwise, I'll be tempted to come. Sinyi mmepotelea Nairobi.
Yes.
Hapa ndo maneno iko. But again, if I'm fully here, who's going to take care of those patients who are in the rural, who cannot afford it? Who will?
True.
So we really have to have commitment. We have to be intentional. That we need to be the change that we want to see. So more than doing that, we are training young doctors. And not only local training, we are training gynecologists from across the continent. I mean, in a few weeks, we are having a delegation of about 10 very senior doctors from Nigeria.
Amazing.
Coming and seeing what are you guys doing different. And I invite you for that as well. Please make sure
you'll do so.
Yeah.
Now, as we conclude on endometriosis, because we also want to see fibroids, we want to also understand it, because these conditions are very they look somehow similar. We'll come there.
Yeah.
So on endometriosis, let's conclude there. What do you have to say concerning the endometriosis?
First of all, is to appreciate you. It is my parting shot? No. It's my parting shot, kind of. Okay.
For endometriosis, then we dive to fibroids.
So first is really to thank you and the Kenya Times for finding it necessary to talk about a condition that is not talked about, and to demystify a condition that surrounds a lot of myths, and to give hope to many women suffering in silence from endometriosis. And I think we are on the right direction. No question about it. And I'm really happy, particularly for Kenya, because if anything about endometriosis will happen in Africa, it's going to start here. No question about it. And possibly it's going to start with the guy that is sitting right in front of you. This is it for me. I'm not doing anything else. This is it. After I finish this, I'll go back to Kirinyaga and farm. So I'm glad that now these conversations are intentional. We are finding spaces to talk about this. Women are being empowered. We can talk about their reproductive health. We can mention the word vagina.
True.
On the mainstream media, and nobody says, how can you talk about that? It's a taboo. Come on now. So when we start empowering and demystifying these myths have been held for a very long time, then we are having the right conversation and we are heading the right direction. So let's keep talking about it. And there's hope.
Okay.
Endometriosis is not a death sentence.
It is not a death sentence. Let's cross to fibroids, just because of time. Very fast. Many people confuse endometriosis and fibroids.
Yeah.
What is fibroids, Dr. John Njagi?
First of all, there's no relationship between the two, fibroids and endometriosis. Let's first put it clear. And you cannot mistake one diagnosis for the other. Reason being, their symptoms are different, their presentations are different. Now, going to the definition. Now that we have done definition of endometriosis, fibroids are tumors or growths that start on the wall of the uterus. It's very common among African women.
Why?
Don't ask me
Why not Western women?
Well, again,
That is very serious.
Again, some of those, you know,
Because actually, fibroids, many women talk about it.
yes,
More than endometriosis.
yes.
Why do you say it mostly occur to women, African women?
Because that's what we have. Actually, that's what we have
more
found.
Than Western women.
Yeah, that's what we have found. So there are certain conditions which prevalent among certain different ethnicity. So, for instance, we find there's a certain conditions which are, prevalent among the Caucasians and so on. Apparently, this is just one condition that we know, again, without explanation how this happened, that is very common among African women, and it can run in the family. We actually find that 70 to 80%, it's a big number, of 70 to 80% of African women in their lifetime, they are going to suffer from fibroids. So that's why we know fibroids. That's why, in Africa, we are good at fibroids. We see, we smell, we can manage. Fibroid is not a problem. All right. So, again, adenomyosis, sometimes adenomyosis, remember we say there's growth can be mistaken, but this, the symptoms are different. So fibroid, we say, are tumors that are growing on the wall of the uterus. In most cases, not symptomatic.
Okay.
In most cases, we don't need to do anything about it.
Okay.
When they become symptomatic, the commonest symptom is heavy bleeding. Heavy bleeding.
Heavy bleeding.
Now, it's going to mean this fibroid, it's close to the inner lining of the uterus. Make sense? Mm-hmm. So if this fibroid is closer to the inner lining of the uterus, then that means the surface area is going to be enlarged. There's going to be more blood, blood vessels. This woman will have heavy bleeding, and these fibroids can grow to significant, big sizes.
Thing.
Yes.
Now, when it grows and become big, maybe a woman wants to be pregnant. So, where is the space point?
So, that's where now survival for the fetus. Who has bigger muscles? Is it the baby who's trying to grow? Is it the fibroid? Unfortunately, we find that the baby, in most cases, loses the battle. So you're going to have another presentation. If you have big fibroids, there's going to be pregnancy losses. There's going to be an ability to get pregnant. So in that cases, whereby a woman has had recurrent pregnancy losses with fibroids, those fibroids need to be addressed.
And it is tumor. Fibroids are tumor.
Not
endometriosis, we said it is a growth.
It's a growth.
So meaning fibroids are tumor that can be removed.
Yeah. So again, all these words kind of used interchangeably. Tumors, growth, it's more or less the same thing. Again, it just depends. So let's say any irrespective of the size, whatever size, call it a tumor medically, call it a growth, but now the fibroid usually arises from the uterine muscle cell. So ni ile cell moja ambayo, you see, our body are well regulated. So what are tumors or cancers? Is when those cells have lost control. Now they just can become whatever they want. They can grow. That's what
anywhere.
Anywhere. They lose their ability to be contained.
And are they cancerous?
The fibroids are not cancerous. That's a good thing.
Okay.
Yeah.
So when a patient maybe identify that she's having fibroids, and she calls you, maybe a professional, Dr. Njagi, I'm suffering from fibroid. And maybe she's so much worried that it is cancer. So you confirm to her that it is not.
So if it's fibroid, if it says, I'm having this and I think it's fibroid, could it be cancer? The answer is, if it's fibroid, no, it's not cancer.
Meaning it can be addressed later, not an urgent address.
Absolutely. Well, however, it depends.
What about the pain?
It depends. Fibroids usually, in most cases, fibroids don't cause pain. In most cases. However, when the patient calls and says they are fibroid, the first question you ask them, how are these fibroids bothering you? What are the symptoms? If there are no symptoms, leave them. Just leave them. They are not symptomatic. We're only going to start addressing fibroids that are symptomatic. Now, the symptoms is everything we talked about. They can be so large whereby they are compressing on organs, the bladder, you cannot hold the urine for a very long time. Sometimes they can compress on the ureter, and the urine is not flowing very well from the kidney starts swelling. So all these we are looking, what is your problem? It can actually be that I am mentally distressed. Now that's a symptom itself. It does not bother. I don't have any problem, but I just don't want that thing in my body. Now that patients need to. So you don't say, oh, it's not bothering you. You have no medical presentation. As long as the patients feel that they require to. The first thing is to educate them.
Okay.
Give them information, and then you fully give them autonomy. What do you want?
What do you want?
What do you want? It's
The
never
option.
What do you want? It's never about you're coming to Dr. Njagi now. He's the endometriosis surgeon from Kirinyaga. You know, he's the only one in their village, and now he's I'm the only guy who can tell you. So go do this. Absolutely no. My responsibility. My responsibility as a doctor is to give the patient as much information, unbiased information, to help them make decisions and only make recommendations. So I'll say, for this, this is it. For this, this is it. It can be this or this. We are finding these are the options of treatment. Given your circumstances, I feel you might want to consider this, you might want to consider this. It's really up to you. These are the benefit, these are the risks. Everything has benefit, has risk. Please make a decision. Now you empower the patient to make their own decision.
Now, as we conclude, Dr. Njagi, because of our time, my producer is telling me that time is not with us. There's a question here coming that someone is asking, can fibroids grow one or many?
Yes, it can be
is
one.
Is it a one thing that can grow?
Let me say,
I've increase in size.
I've removed one fibroid that was about, let's say, 20 centimeters, a single one, and I've removed about 90 fibroids. So they can be many different variable sizes. So it can be 1, it can be 2, it can be 10, it can be 50, and it can be variable sizes. So we cannot say this is the direction. The question possibly get asked, if you remove them, are they going to come back again? And I always ask, where did they come from in the first place? Because in removing them, I've only taken care of what was there. So there's a risk of recurrence.
And what is the causes?
Again, we don't know.
Okay.
Just like
Endo. Okay.
It's not very clear.
Thank you, Dr. Njagi, for coming. It's been an amazing conversation. Where can they find you?
Now, well, first of all, again, once thank you for having us here. And to our viewers, again, I really hope you found this information important. And if you found it information, please make sure that you're sharing or you're talking to somebody about it. And I think you should join the family of the Kenyan Times. I think these conversations are amazing. Now, should you really want to get to find where we are, again, you can follow us on our social media handles. That is Dr. Joe Njagi. Easy to find. We run a clinic in Nairobi. We also run a clinic in Kirinyaga County. You want our phone number? All right, that will be 0799 500 555. That is 0799 500 555. And again, from endometriosis, please don't walk by yourself. We are there to walk this journey with you. And for the fibroids, please don't let them bother you if they're not giving you significant symptoms. Well, thank you so much. Until next time, Asante sana.
Thank you. That is where we conclude our conversation together with Dr. Joe Njagi. See you next time. I've been your host, Nixon Njau.